I'll just invite our panel up, T, David and Adam, just if you pop into the chairs. While you're doing that, despite my rather distracting attempts at technical support last time for the first plenary, I forgot to put up this. This is just a link to a website where a whole lot of the references that were discussed and some extra ones that are also there for you to just grab. While you're scanning that, and I'll put up another one for this session at the end of this, so yell out if I forget to do that. This third session is on neck rescue, scalpel versus scalpel. What do I mean by that? Before the dark times of the pandemic, the sort of staple at the airway meetings was the cannula versus scalpel debate. I don't want to get into that at all today. No matter which side of that you fall on, cannula first or scalpel only, the one thing that's universally agreed is everyone must know a scalpel technique for neck rescue. Even those people who support a cannula technique support a very particular cannula technique that's been developed by Andy Higgs that's quite specific in the way you do things and the equipment that's used for it. And those cannula first people would be quite disparaging of other alternative cannula techniques. And one of the problems with that cannula scalpel debate was treating these two groups of techniques like they were homogeneous. There's a lot of heterogeneity within the cannula techniques and within the scalpel techniques. And Andy Higgs determined that there were good cannula techniques, which is his, and there were others that were doomed. And so when you look at the broad data there, that's one of the problems with that. The same likely applies within the scalpel technique, and I think Andy, when they developed their scalpel technique, also found that there are good and bad scalpel techniques. So the premise of today's discussion is really around, when you come to use a scalpel technique, whether it's as a first line thing or as part of a cannula first approach, moving to scalpel if that's not successful, which scalpel technique do you use? And to help us solve that question, we have some experts from across anaesthesia, ED, ICU, and ENT. So I'm going to start with our virtual guests first. Has that worked? Yep, beautiful. So, our first panellist is an ED intensivist from New York. He's done fellowships in trauma, surgical critical care and ECMO. He's currently an attending or consultant in the local terminology at Nassau University Medical Center in New York, as well as being a physician coach with interest in optimisation of human performance. He's probably best known for his podcast, MCRIT, which focuses on resuscitation and ED critical care and has been downloaded more than 50 million times. Please welcome Scott Weingart. Andy Higgs is a consultant in intensive care medicine and anaesthesia in Cheshire in the UK. Some of his achievements include being past treasurer of the Difficult Airway Society, a past board member of the Safe Airway Society. He's on the executive committee of the Universal Airway Guidelines Puma and a member of the DAS 2025 Guidelines Working Group. Basically, he's a bit of a guideline whore, just desperately trying to get his name on something that will get a lot of hits. I'm sure he's about to point out that his 2015 critical care airway guidelines actually achieved some remarkable outcome in terms of downloads, and one of the best papers of the last 10 years or something, wasn't it, Andy? Anyway, as you can see, he's going to be great.
One or two people read it.
He's actually one of the first people I turned to for airway advice. Please welcome Professor Andy Higgs. Next panellist is a consultant airway and laryngeal surgeon at the Queen's Medical Centre and the Professor of Laryngology and Clinical Informatics at Southampton in the UK. His practice is exclusively focused on treating airway, voice and swallowing disorders in adults. He's probably best known for his work with Anil Patel on use of high-flow nasal oxygen for the Thrive technique. Please welcome Professor Reza Nouraei. Staying in the surgical vein, but coming live, our Safe Airway Society board member, David Vokes, is a laryngologist and head and neck surgeon at Auckland City Hospital, where he also serves as the clinical director of the Department of Otorhinolaryngology and head and neck surgery. He has completed his fellowships in both head and neck surgery and laryngology. His clinical focus is on disorders of the voice, upper airway, swallowing and head and neck cancer. Welcome, David. T Tito at the far end there is a UK-trained specialist anaesthetist currently based in Western Australia. She holds professional portfolios in airway management, simulation-based education and human factors in healthcare. Among her appointments, she is the chair of the Human Factors and Ergonomics Society of Australia and a board member of the Safe Airway Society. Welcome to the panel, T. And finally, Adam Rehak, who you've probably had enough of by now, is an anaesthetist and clinical director of surgery and anaesthesia here at Royal North Shore Hospital. He has extensive experience in healthcare education and simulation training and is interested in safe airway management to the extent of being the co-founder of the Safe Airway Society. I'm told that much to the disgust of our president, he defends the consumption of rosé wine. I'll leave that for a discussion later. What I want to do before we get into this is just define what I mean by neck rescue. So this is my sort of exhaustive legal definition, but the key bit of it is I'm talking about accessing the airway through the front of the neck in the time-critical situation of insurmountable upper airway obstruction. And really the distinction I'm making here is between ePhoner or emergency phoner and phoner. So front of neck airway can be a surgical tracheostomy that's done over half an hour. But we're going to focus today is on specifically techniques for ePhoner. And because the E gets dropped in and out and that distinction gets lost, even in DAS documents, we're going to use the term neck rescue to specifically describe that technique. Okay. So, actually I have to show another slide. Before this, what we've done as a starting point is to agree with the panel on some ideal characteristics of a neck rescue technique. So I'll just run through these. That it should be effective, optimising the probability of success. Rapid, suitable for the time-critical situation of insurmountable upper airway obstruction. It should be robust, by which I mean we can use a consistent technique across an array of contexts and an array of disciplines. So that might be palpable or impalpable anatomy, pre-hospital, ICU, ED, anaesthesia, and ideally adults and children, but children are a bit different even with use of the scalpel technique at all. So we're going to restrict our discussion to adults today. It should be safe with minimum risk of harm to the patient or the clinician. It should be simple in that it's easy to learn, retain and perform. The equipment should be readily available. Scott said it should be ubiquitous, easily sourced with a minimum risk of encountering supply chain issues. Particularly important to those of us who, I think in Australia and New Zealand, the common practice of having point of care kits at every bedside, it needs to be cheap to enable that to happen. It should be familiar, so ideally equipment that people have used in other contexts and know how to use rather than something that's idiosyncratic and they wouldn't use in any other situation. And it should be minimally intimidating. The confronting nature of the procedure, as little as is possible for this, shouldn't be something that becomes a barrier to people doing it. I will start by going to our panel now and asking them, is there anything else you want to comment on that list, just as terms of our basis for discussion? T, you mentioned something to me last night, so we might start there.
Yeah, thanks. Not that I think something exists at the moment, but as we're talking about a utopian world, that is applicable for everything. I think what we've heard today is sometimes in the various environments, we're actually seeing people as a single operator. I'm very blessed working in a teaching hospital where I have anaesthetic technicians and we've also seen the value they add. But actually, do we need to have or think about those scenarios where what is effective when you are the only lone operator?
Okay, and so that's a difficult one to satisfy. And what we'll find as we go through this is a lot of these are not necessarily mutually exclusive, but they're often conflicting. We often have to trade off one of these factors to the other. Any of the other panellists want to comment on those just at the outset as our basis for discussion?
Can I just say, Nick, I think whatever technique you use, the concept of a front of neck access in an emergent fashion is always going to be a little intimidating, because ultimately it's a sign of failure and it's also going to leave a permanent mark on the patient as well. So I think we've got to accept that just about anything we do in any way is always going to be seen as intimidating by anyone, and that includes us surgeons. If we're confronted with doing that, as I mentioned, it's a sign of failure and it's going to permanently mark our patients.
I would challenge the mindset that it's a sign of failure. It's a sign of
Attention.
doing what needed to be done to save the patient's life, but we can come to that later. We have sort of ranked them in a rough order. I'll come back to the intimidating part of it at the end and how relevant, or in a moment, and how relevant that is. What I want to do is just show a couple of quick videos of the major techniques so that we all know what we're talking about. So I'm going to show a video of the main techniques that I think get used are the percutaneous Andy Hurd thing, the stab and twist, not percutaneous necessarily, but sort of minimally invasive, which is what DAS teaches and what Royal Perth and Fiona Stanley in Western Australia teach. And really, I think in anaesthesia is probably the predominant technique. The other one is what my experience is many emergency physicians do is this more open technique, making a long cut in the neck and scalpel finger bougie, actually putting the finger into the trachea. And then there are other variations, particularly there's other kits and things, and one we'll show you is a quick demonstration of Scott using what's a device developed by Richard Levitan called the Crike key. What I'll do, I'll show a quick video of the Hurd technique, and then I'll just go to T if she's got anything to add on that. We won't get into the nuance of it yet, but just what you think the headline stuff is so we know what everyone's talking about. And then I'll show the Scalpel bougie one, which I think is a video by Rich Levitan. Then I might get just Scott to quickly comment on that before we start breaking them down. So the first thing here is the Andy Hurd technique.
The non-dominant hand identifies and stabilizes the cricothyroid membrane. When the cricothyroid membrane cannot be identified, the trachea may be used as an alternative location, but only if it is easily palpable. Using the dominant hand, a stab incision is made into the skin and the underlying airway using a size 10 scalpel with the sharp edge towards you. After feeling a pop as the blade enters the airway, gentle traction should be applied to the scalpel before it is rotated 90 degrees with the blade sharp edge ending up pointing caudally. While maintaining perpendicularity, the blade should be pulled towards the anaesthetist, producing a triangular hole in the skin and underlying airway. The operator should now switch hands so that the non-dominant hand holds the scalpel. The dominant hand now holds the bougie parallel to the floor, pointing away from the anaesthetist. The tip of the bougie is then inserted into the airway whilst maintaining contact with the scalpel blade and using the blade as a guide into the opening of the airway. It is usual to feel a pop as the bougie enters the airway. The bougie then needs to be rotated and aligned with the airway before it is advanced into the trachea. Advancing the bougie into the airway should be a smooth procedure requiring not more than 2 fingers and gentle pressure. While advancing the bougie, tracheal rings can often be felt. If tracheal rings are not identified, it may be necessary to feel for hold-up of the bougie to exclude gastric or pretracheal insertion. This should be again performed with gentle 2-finger pressure only. A 15 mm RapiFit connector must be attached to the Frova bougie to allow self-inflating bag oxygenation.
So this phase of it is something that the Andy Hurd's group teaches, but the DAS technique don't do this portion of it, ventilating down the bougie.
The tube is then advanced over the bougie. While the non-dominant hand stabilizes the trachea, the dominant hand guides the tube using a continual 360-degree rotation technique to allow for smooth insertion of the tube into the airway. Note that we no longer recommend jetting down a bougie.
Okay, so I might come to T, and I might start just by asking about that exact point. That's that step of ventilating with the 15 mm connector down the bougie before railroading the tube. Am I right in saying that's something you still teach over West? And just why you feel that's an important part, because I think DAS dropped that.
It is still taught. The reasoning behind it is essentially we have found that despite the technique, as you've seen, being performed absolutely perfectly, the trachea the tube doesn't actually go into the trachea. What's happened is the bougie is paratracheal. And therefore, at that stage, after you've performed putting the bougie through, putting the RapiFit will give you an early indication at that point whether or not you get end-tidal CO2 and how it feels on the bag. And so it just gives you early recognition that it may have failed.
And I presume less likely to blow up the subcutaneous emphysema and make subsequent attempts difficult. Okay, so let's have a look at the... Scott doesn't approve. Go on, speak your mind, Scott. Go on.
Come on, I mean, it's bad enough that... You know what? Show the other technique, Nick, and then I'll put it all at once.
I'll show the other technique and we'll come back to you. Okay, so let's look at the... so this is the scalpel finger bougie. There are a few nuanced changes to this. I apologise, this is not a great resolution video I've managed to get here, but this is Richard Levitan taking us through this technique, and we'll talk about some of the nuanced changes.
1 and 3, because number 2 is going to verify where the CTM, where the cricothyroid membrane is after I make the vertical incision. I pick up the blade, choke up so I don't have a lot of distance, rest my hand on the sternum. I make this vertical incision from about mid-thyroid down over the cricothyroid and just onto the beginnings of the trachea. Now, this incision point at that point is not, or this incision rather, is not very aggressive. It's just through the skin. But what it does is it allows my index finger of my non-dominant hand to explore that space. The cricothyroid membrane is a little soft space between the thyroid cartilage above and the cricoid cartilage below. The trachea has a water bottle softness descending into the sternal notch. The thyroid, if I go out laterally, is broad and flat. So once I've convinced myself where the cricothyroid membrane is, with my hand still resting on the sternum, I horizontally enter the cricothyroid membrane and I bring the blade towards me. I then flip the blade over and I go away. But I've made this incision, I take out my knife, and I've made the incision large enough for me to get my finger in the hole. And this is a very important piece, because without having your finger in the hole and knowing it's large enough, you may not be able to pass the tracheal tube in. A common error of this procedure is people make too small a hole and then they start shoving things in which don't go into the trachea but instead go subcutaneous. But my finger's in the hole and I can feel it. I take my bougie, and you can go right to a tube here if you want, but I'm going to take the bougie and I'm going to pop this in. And now I'm taking my 6/0 tracheal tube and I'm going to railroad it down. But I think in terms of sequence, it's important that we go scalpel, finger, and then tube or bougie. Because if you don't...
Okay, time to unleash Scott Weingart.
All right, so I have to preface with the idea that you should not listen to two groups of people on what technique to choose. You should not listen to the people who have done none on real life and they've only tried in the lab, because so many techniques will seem so appealing that fail under fire. And the other people you shouldn't listen to are the people who have done 3 or more, because for them, any technique can be used. You've lost the stress response, you've lost the adrenalization, and so you shouldn't trust me for which technique to use. I've done a lot of Chrimes, and I think it's not because I'm bad at airway. It's because for a large part of my career, every asystolic cardiac arrest patient that came in without a tube got a Chrimes. And then from that point on, I've done about 1 a year. And I've tried all the techniques. The people you need to listen to are the ones who have trained and done their first crike. And for those, the scalpel finger bougie will be successful every time. I have 50 emails in my box from people who trained on scalpel finger bougie on a model and then performed their first crike successfully. Now, the Andy Higgs technique is beautiful in the lab. It's beautiful if you've done a bunch of crikes. But Ty pointed out the failure mode, which is you don't have any confirmation of where you are without that end tidal CO2. And I've had cases of paratracheal placement. Most of the bougies in the United States do not have the ability to ventilate through them. You have to buy a specialized bougie that is hollow with the wrappy connectors. We don't have them. We want a technique when you know you're in the right place before you even put the bougie in. Beyond which, it's blade agnostic. It will have the endotracheal tube pass for the reason Rich mentioned. You're dilating with your finger. It will work in the trachea if you're not in the cricothyroid space. It is, in my opinion, the proper surgical airway technique.
Okay, so it's interesting. We have a live sheep wet lab at my hospital, and our team there teach Andy Higgs technique. But at the moment, the DAS are writing new guidelines, and I'm involved in writing the universal airway guidelines. And both of us are discussing what technique to recommend. And so this is sort of where this came up from. I got these people who are used to the Andy Higgs technique to try it in the wet lab. And the description from someone who has done the Andy Higgs technique a lot of times and see it fail a lot of times too, even in the lab, was it is devastatingly effective. And that was, it is very confronting, it is very bloody, but it absolutely works. And I suppose the thing is, isn't that what you want? When things get to that very pointy end, have we put too much emphasis? I might come to Reza about this. Have we put too much emphasis for anaesthetists on making the technique palatable? Before I get your answer, Reza, I'm just going to show one more video. This is a video George Kovac from Halifax in Canada provided me with. This is a video of, again, the scalpel bougie in a cadaver. But you'll see there's a little catheter there that he's put blood in to make it bleed. And I think Scott can maybe comment if that's this sort of gets a realistic thing. But I think in that first picture of the Higgs technique, they talk about a little triangle. I think the reality is you don't see that triangle in a real patient because there's just blood. And I think a lot of the issue here is I imagine that these are blind techniques once you make a cut. But I'll just show you this and then come to Reza and maybe David for thoughts on, do we need to just suck it up, the confronting bit, and just get on and do it?
All right, this is the scalpel finger bougie approach. What you're going to notice is the mobility of the airway, of the larynx. You need to stabilize that with a laryngeal handshake. You really can't feel landmarks in this patient here. Very difficult to know where you are, but roughly, again, what you know is I'm gripping the larynx with my thumb and my middle finger, and I can go about 1 centimeter above that plane that I'm gripping, making a vertical landmark incision using the belly of a number 10 blade. And with a couple swipes, you get some bleeding. Now you're repalpating within that blood to try to find the cricothyroid space. And my DIP finger is flexed here to protect my finger. Stab incision, as you see here, protecting the distal finger. This is the Ramsey approach that chefs use. I'm going to be able to do that. So I drop my index finger in there and I'm protecting the airway from bleeding, but I can definitely feel that I am in the cricothyroid membrane space there with my finger. Then follow with the bougie behind my finger so I can feel it along the pulp of my index finger. So here's the blade that's in there, 10 blade. It comes out, follows with the finger, and you won't mistake this feeling, right? You got cartilage all around your finger, and then you Feel the bougie go posteriorly, followed by the tracheal tube. Can't stress enough about using the finger as a placeholder. You won't make the error of being in the wrong place. Follow with number 6 endotracheal tube. Inflate the cuff and ventilate where you...
Okay. Reza, I suppose 2 questions. One is that similar to what you would do in an emergent situation as an ENT surgeon? And 2, that broader question of, is intimidating really an issue, or are there ways around just training people to desensitize them to get them over that? And we should just be choosing the most effective technique?
Hi, thank you, Nick. It's almost exactly what I would use in an emergency. There's several good things about the video that you just showed. One of them is that the operator is standing from a surgical perspective on the correct side of the patient. And the other thing that, I would say is old adage that big mistakes are made through small holes. To make a large enough incision to make the cricothyroid membrane palpable as something that you would do to begin with has quite a lot of advantages over having a decision point about whether your membrane is palpable or impalpable at that stage. And when I go on courses around this, one of the things that both David and I said in the past is that the only 2 things that you can't really fix in the airway is either a dead patient or a brain injured patient. Anything else, by the time you get to that point in an emergent situation, can be fixed. So I would go big. I would definitely use a finger to try and palpate where we are, and then I would go into. And the other thing that I admittedly, it's more than 3 times, so perhaps I don't qualify for this according to Prof's comments. But even when you think that you probably are all right, I don't go for the emergency tracheostomy in that situation. You secure the airway with a cricothyroidotomy first, and then if you need to convert to a tracheostomy, because you could be there thinking that I'm going to be there 2 minutes, and we know all what surgical 2 minutes are like. And in an airway situation, you don't necessarily have that time. So I favor the finger and bougie technique.
Okay. David, anything to add to that?
So I think I am an expert because I've done 2. And so
you're right in Scott's sweet spot.
I'm right in the sweet spot. So that's the technique I've used, definitely. I think having a vertical incision is absolutely crucial because the most difficult part of the whole procedure is localizing where the cricothyroid membrane is. And that's where we're going for. So we're doing a cricothyroidotomy. And I know that you're not a big fan of that term. You think that's a little intimidating, like neck rescue better?
No, neck rescue is an umbrella term.
Okay. Yeah, so to be precise, we want to get into the cricothyroid membrane. We want to do a cricothyroidotomy, but there are lots of variations in position according to age and gender, and also according to pathology. So a vertical incision allows us a little bit of leeway if we don't quite get it right the first time with surface palpation about where that cricothyroid membrane is. Also, remember that the airway is a midline structure. It generally is a midline structure, so we're going to stay in the midline. And also, most of the major vessels are not in the midline. Okay, anterior jugs are paramedian. You might have some transverse vessels communicating, but it's generally less vascular in the midline as well. I actually also advocate, I think it's in one of Levitan's other videos, also feel the sternal notch. That's a really important landmark. People talk a lot about the thyroid notch and the cricoid, but also I often start with the sternal notch because that's midline and that doesn't move.
Yep.
Yeah.
I appreciate that the cricothyroid membrane is the preferred place for lots of reasons, but I assume that in a situation where you're, despite that dissection down, if you weren't able to identify clearly where the cricothyroid membrane is, well, firstly, does that ever happen? Or does this, in most cases, you can clearly feel the cricothyroid membrane?
Absolutely. And it's okay if you get into the trachea. But I think what we're trying to say is we want to go for a standardized procedure to minimize confusion, to optimize our outcome. And so we're encouraging people to go for the CT membrane.
Yep.
Yeah.
I'm going to come to Adam in a moment, because Adam has taught for a long time the herd technique and is an advocate of it, but he's also had use of in anger. You're probably also in Scott's sweet spot for doing neck rescue with the scalpel finger bougie technique as well. I want to show, moving on to efficacy. So, you know, Scott made the point that the scalpel bougie technique often, the stab and twist, to make it clear, I find the terminology scalpel bougie and scalpel finger bougie is a bit, but the stab and twist technique, the herd technique, fails, and even T has acknowledged that. This is some video from a sheep lab. So the protocol at this lab is to take the sheep to SATs of 90, and then the participant is called in, having been trained in the procedure immediately prior, called in to perform neck rescue. As you can see, by the time knife goes to skin, the SATs have often precipitously fall. There's no sound on this, and I'll just ask for both George's previous video and for this, if I prefer you didn't take any videos and post it online. So George has specifically asked with the cadaver one if that could not be circulated. So here you can see they've done the stab and twist, pulled out to get that triangular shape. And I'm sure T would point out here that this is not the correct technique. That bougie, the herd technique is very dependent on that bougie being perpendicular to the patient, parallel to the floor, or that's where you get into the trouble of going paratracheal. Now, SATs are down to 38. They're doing the ventilation down the bougie, and what happens is they do not get CO2 back, and you'll see them subsequently determine, the discussion here is they've realised they're paratracheal. And I would suggest, and I imagine T, that you would say there's a technique problem that has led to that. I would raise the concern, though, that this is a technique problem in someone who's just been taught it and is doing it in a relatively non-stressful situation. 2 years later, when they're called to do this and they're stressed, are they going to do it worse? So there was a study that they did at this wet lab around this. So they're ventilating, still no CO2, SATs are down to 22, and they make the decision here to pull out and start again, that they've gone paratracheal. Interestingly, the comment is when they reinsert this, that the feel of it going in the bougie when it goes into trachea is quite different to when in paratracheal. I can't remember what I was saying before that. Anyway, probably wasn't.
Yeah, I mean, it's absolutely fascinating for me to see the technique performed, as I meant, perfectly, you know, in inverted commas, and clearly there is a flaw with the technical technique at the moment. So I think we'll discuss the nuances a bit later, but you know, we've seen ED. So this is not people who are scared to use the scalpel. You know, sometimes there's this argument about anaesthetist being confronted with cutting the neck. I've seen ED pre-hospital do the same mistake, as in not because they performed the procedure incorrectly, simply because there is no endpoint. You know, there's no tactile feedback to let us know that you're in the wrong place.
So now you see they're ventilating through the bougie. This time they are getting CO2 back. SATs are now rising after about 30 seconds after their first ventilation, and they'll then go on and put the tube in. What I was going to say is, I might just move this on in the interest of time. They corkscrew the tube in. Interestingly, actually, I'll let you see it because there's a lot of blood even with this technique up the tube, and they actually don't get CO2 back when the tube goes in. So they did. What I was going to say is they did a study here of comparing. Now, the point of the study was compare cannula and scalpel, but the interesting thing is in the wet lab they had about 43 patients, and about 15 of them scalpel bougie failed, and in more than half of those, it was because it was paratracheal. So this is a problem with this, and what I'll come to Adam in a moment is to ask, you know, have we sacrificed efficacy for something that is for palatability in doing this? And you know, as Scott sort of alluded to, it's great if you do it perfectly, the stab and twist technique, but only minor changes make it not robust and it can fail. You can see there they've ventilated, they haven't got CO2, but they have got confirmed oxygen delivery because the SATs have continued to rise, I think, and come up to 100%. but there's a bit of a fiddle round before they do get CO2
Nick,
back.
can I quickly add another
Yep.
flaw when you can get CO2? So what we've also seen is where the trachea is, the tube is in the trachea and you get your end tidal CO2. But what has occurred is during the corkscrewing of the ETT, if you don't train your anesthetic assistant to hold onto the end of that bougie, the actual tip of the bougie goes in further and has actually caused trauma. And so what you're getting is this false initial rise, and you get a bit of ventilation, but you're basically causing a tension pneumothorax that occurs later. So again, having end tidal CO2 in this technique is not as robust as we would like to think.
Okay, you can see there's a lot of blood in the tube, which I think is probably maybe why we're getting CO2, and now they've got a good CO2 trace. So I'm going to come to Adam, and then I'll come to you, Andy, with the same question and then I'll come to Scott. Okay, Adam, go. And then we'll wrap up.
Look, in terms of explaining, answering your question, I think I need to explain my journey from having taught the Andy Hurd technique for a long period of time to the point that I performed my one and only emergency neck rescue, where I chose the Levitan technique, or the technique you've described there. And I think we have to say that the problem we've been comparing here is the technique that is taught for a very superficial, palpable neck anatomy, and we're not talking about what do you do if it's non-palpable, whereas the second technique we've discussed is appropriate regardless of whether it's palpable or not palpable. It's just you've got to go deeper. And the problem I had when we constructed some bleeding deep neck models was that I increasingly saw that you could palpate neck anatomy that was well more than the distance of the length of a scalpel blade beneath the skin. So providing you pushed really hard with the scalpel, you might be able to get to the cricothyroid membrane for this superficial stab and twist technique. But if at any point you released pressure on that scalpel to reach for the tube or reach for the bougie, you were out of that cricothyroid membrane. And I increasingly saw people walking around didn't have necks that looked like sheep necks. It was not binary terrible necks versus very skinny necks. It was a whole range of necks, and I got really concerned that this was going to be a difficult technique. So we got to, and I'll tell some, so I think the answer is yes. We've tried to, in the need to standardise and the need to simplify, we've gone down one step. I would really love to know how DAS came to their deep neck technique, because I absolutely don't believe it can work in the real world at all. That when you get a deep neck, you need either a separate person as a retractor or retractors to hold the neck open, or you need your other hand to hold it open. If you're going to do a scalpel and hold a scalpel in the cricothyroid membrane and then reach for a bougie with your other hand, that tissue's closed. You ain't going to be able to follow you just cannot do it in any of the bench models I've created. And I would argue it's not doable in a human being, but I'm happy for Andy to tell me otherwise. You need a finger in the hole in that situation to be able to get it in. So this brings us to my one and only, which for reasons that a number of people alluded to, wasn't immediately successful. So I was sitting in John Gatwood's office. We were actually discussing, I think, SAS 2022 or something at the time, and he was on for the resus team. Code blue goes off. I said, I'll come with you. We walk into the cath lab, and a guy's just arrested. He's been rolled off the cath lab table onto a bed in a poorly lit room with no room, and he's got pulmonary edema pouring out of his mouth. One of our very experienced, very capable anaesthetists has just failed to intubate him with the second attempt. I've thought about it. Even if we could get a cannula in there, what good is this going to do? The guy's got no output. We've rung theatre, and he's going to be crashed onto ECMO and go for emergency reperfusion. He's got pulmonary edema pouring out of his mouth, and he knows he needs positive pressure ventilation. He needs a tube. There's no point fiddling around with a cannula here. He had virtually no neck, or a pretty solid limited amount of neck, and we made an early decision, rightly or wrongly, that we should go to neck rescue. Unfortunately, the only position available to me, or it may have been reflex from having taught Andy Higgs technique so long, was to go onto the left-hand side of the patient. And I think that is where I fell short in this situation, that as Reza has pointed out, and as Rich pointed out, you actually need to be feeling from above to feel down into the thyroid cartilage and the thyroid. Hand on the sternum to feel for that cricothyroid membrane just wasn't effective. I had no light, it was just terrible situation. And because he'd arrested and was in massive right heart failure, the minute the scalpel went in, there was a point there where I looked at John and I to see whether we were bleeding, because I could not believe that much blood could come out of one patient. It was literally a bloodbath. The minute we went in under the skin, it was just bubbling out. And there's absolutely no way you could do it other than using a tactile technique of getting the finger into the hole. A number of times I found the hole, but I was not prepared to use the Ramsey style technique of putting that scalpel, and I'm unapologetic about that. Unless you teach that technique of running a scalpel down the outside of your finger, I do not think you want to be sticking a finger and a scalpel in the same hole at the same time. It was terrible. Eventually we got someone with an iPhone to give me some light. Eventually we got some suction, but it wasn't until the ENT registrar arrived with some actual cat's claw retractors that we're able to easily find. So it was delayed. That wasn't a success. It wasn't a success in terms of was the patient survived, but I suspect the amount of time off CPR that it took to get that airway in was, you would call it a failure. We were probably 4, 5, 6 minutes before we were able to, maybe longer, because time really is hard to, it may have even been longer. So I think there was some learnings from that. Stand on the right-hand side of the patient if you're going to perform. If you're right-handed, stand. Exactly, stand, but the opposite side to the standard scalpel bougie technique that is taught by DAS. Have a second person as human retractors if you haven't got actual retractors, and light and suction really help. And choose your patient that hasn't arrested, so that the mean systemic pressure isn't massively elevated and you're dealing with normal venous pressures.
So what I'm hearing is, in terms of robustness of technique, that in someone who's got a deep neck, and I think even T will agree with this, that the stab and twist as advocated by DAS for all comers is not a good technique in that situation. Andy, I'll come to you and then I'll just follow through the rest of the panel to make comments. Go.
I think I would just echo a lot of what's already been said. To answer Adam's direct point about the DAS technique, of which I'm not a great advocate. Chris Brook, who led that group, has used it successfully. So like anything in airway management, you can use a suboptimal technique and it will work a lot of the time.
Has used it in a impalpable neck situation, or?
Well, hold on. Well, I was just coming to that. I mean, I reviewed the 2015 guidelines. I wasn't part of that group, but I don't agree with the technique. I think DAS has moved on itself, and that's why we're rewriting the 2015 guidelines. And Reza and I are both on that group, and I think it will be. It's kind of, we haven't come to that point yet, but I think we're edging towards scalpel finger bougie tube, because Reza and I are very, very strong advocates of that technique. But I think that the thing about front of neck rescue, if you will, is that this is going to happen very infrequently. I've done it 3 times in my life, and I'm interested in airways. Most people just see it once. You have to know one technique that is going to work for virtually everyone. You have to be very clear in your mind every day of your career what you're going to do. And there's only one way to do that. That's to decide what you're going to do, rehearse it in your mind, practice it in your department, and rule out alternatives. Because when it happens to you, you're having the worst day at the office you have had ever, right? If you're an anaesthetist, particularly, I think because of the psychology of anesthetic lost airways, I think you're going to be more angsty than us in ICU or in ED. So you're not in any fit state to go through a complicated algorithm of if this, if they're obese, and if they're completely obstructed, and if their lungs work, and if you can palpate the anatomy and all that, all those questions. You haven't got time. You simply haven't got the bandwidth to consider any of those points. You just got to do it like the army do it. The army do it on the plains of Afghanistan and in Iraqi deserts. They have 85, 90% success rates. They're not even doctors, a lot of these people. And they do it because they have one technique which is virtually universally applicable, and that is a scalpel technique, a scalpel finger bougie technique. So I think that you coming back to your original question about what is the ideal, it also has to work in completely obstructed airway, because unless there's an expiratory pathway, you're stuffed otherwise. So you need a decent sized tube in there. In my world, where the lungs don't work, cannulas aren't going to do anything for you.
We're not getting into
And
cannulas,
you
Higgs.
just need to go into work every day, knowing wherever you go, in theatre, in the ICU, in ED, in the corridor, whatever, wherever it happens, you're just going to do it, and there are no alternatives.
Okay, Scott,
Right?
from your face, sorry.
Has to be universally applicable.
Scott, from your face, I gather you've got a few comments lined up. Go.
Yeah, I'm so happy with what Andy said and what Reza said. And so, first of all, I would not listen to George Kovach on leaving your finger in the hole. That's speaking from someone who has done more than 3. Don't listen to George. It's not applicable to the people who are doing their first one. So we have a rule. If you want to bring a scalpel onto the field, your finger has to point to the sky. And only when that scalpel's gone could you put your finger back down. I would not go anywhere near, I trained as a chef. I feel very comfortable cutting next to my finger. Do not do that during a cricothyrotomy. That's crazy. Love George, love him, but that's crazy. The scalpel finger bougie is side agnostic. It's better if you're on the same side of the patient as your dominant hand, better, but it is absolutely side agnostic. You just make a bigger incision and you find it from below. But absolutely better to be on the right side. But if you're on the wrong side, it still works. And then, Nick, you keep mentioning being confronting. This should be confronting, because if they're in a position where they're going to start with, oh, I'm going to go in with the scalpel stab and twist, and then they realize they can't palpate the anatomy, they've now psychologically set themselves up for failure. You should go into every single one of these knowing it's going to bleed like stink and just being willing to persevere.
Yep. Can I ask you one more, just on
absolutely.
a
And
nuanced
also,
question while I've got you?
same-
Oh, sorry, Andy, go on.
Well, I was going to follow up on the bleeding aspect. Yeah, you can get some bleeding, but actually, I don't think the bleeding really amounts to very much in most of these cases. It looks dramatic because it seems to be blood coming out of a very small hole. But in George Kovach's bleeding model, I mean, it looks very dramatic, but it's actually attached to a 20 mil syringe of Ribena or whatever he's using. It's just 20 mils of blood. It's less than a venesection, or one of my Venflons. It's just, it looks dramatic. It looks worse. People worry about it, but this is a tactile technique. You do not need to be able to see anything. When I teach it, I deliberately look at the class and I say, look where I'm looking. I'm looking at you. I'm not looking down in the hole because my finger is in the hole. And just coming back to T's point about endpoint. Well, actually, you do have an endpoint. You do have a deep endpoint because your finger's in the trachea. You can feel the cartilaginous cage. You can feel the tracheal rings if you get your finger in far enough. And you can feel the bougie running down the bulk of your finger. You can feel it in there. So that is a deep landmark. That is a deep confirmatory landmark. So, and that's the best you're going to get.
Reza, David, can I ask you what, I'll start with Reza, in addition to whatever else you're wanting to say. What are your thoughts on this finger in the hole thing? I noticed that's a difference between obviously Scott's technique and George's technique, and it seems fraught. What would, if you did it, would you have your finger in the hole at the same time? And I suppose people are concerned about losing the hole. Is that a thing, that you've made this hole in the cricothyroid membrane and then you can't find it?
If you are in the cricothyroid membrane and you have made an incision and you've twisted your blade and you've gone from side to side, And again, cricothyroid membrane gives you very definite stop points, the cartilage. And unless you sort of go to it with all your might, you are very unlikely to cut through it. So what I use the finger for is to sort of extend the size of that hole. I wouldn't put blade and finger in together at the same time ever. But, you know, by the time you've twisted and you felt hardness on the left and the right of your incision, you come out, you will find it, and the finger extends. I use the finger as a guide for the bougie, but never as a guide for the blade. And cricothyroid membrane does not calcify in that level. Both cricoid and thyroid calcify, but you are not necessarily going to get sharp edges of things that putting your finger in can damage. So I don't have any concerns about a finger being in there, both to extend the size of the hole for the tube to go in and as a guide for bougie. And it's a very definite palpatory feeling that is very difficult to mistake once you have felt it. I ever so slightly disagree with site agnosticism. And the reason I say that is for this reason. So when I teach it, I say left to left, right to right. If you're left-handed, on the left of the patient, if you're right-handed, to the right of the patient. One of the difficulties I have with the DAS guidelines is this from bottom to up incision recommendation. Now, again, DAS isn't just this tap technique. It's an impalpable membrane would create a large incision. But a problem there is that you're making a decision point, a fork in the road at the worst possible time. So that's one problem. But the other thing is that if you are going from the bottom to top, now we all assume trachea is a very subcutaneous, very palpable structure in every possible neck you could possibly want to do it in, and that's not true. The larynx is where the airway is fixed and it doesn't really move. And the trachea literally could be anywhere with a tumor or emphysema. So you wouldn't go from bottom to top. But the other problem, which I think is more important, back to safety, is that if you make
that looks like
make your incision with no landmark and no skin retraction, or you're going to cut towards your hand from bottom to top. And that's you can slice through your finger in that stressful situation. So I would go left to left, right to right at all times. But other than that, I agree with absolutely everything that's been said.
Scott? And Andy?
Yeah. So look, Reza, I want to make clear, I think I said it, but I'll say it again. I absolutely prefer being on the same side of the patient as your dominant hand. But there is exigencies that exist in the emergency department. You just can't access it sometimes. And in that case, you still retain the laryngeal handshake. Your handshake now is on the cricoid rather than the thyroid. It's not as ideal, but you still retain the handshake. And the finger that goes in, you'll just rotate it 180 degrees once you're actually in the cricothyroid space so that the pad of your finger is still what the bougie rides on. But I'm clear, I want to be on the same side as my dominant hand. But I've done it on the opposite side, and it does work without any real change in technique, except the laryngeal handshake is now on the cricoid and not the thyroid.
Can I just ask anyone who wants to take this, and then I'll come to you in a second, Andy, just so I can get my head around this, you've made this longitudinal incision, you've dissected down till you can feel the cricothyroid membrane directly. At that point, that incision is filled with blood. If I take my finger out before I put my scalpel in, which sounds very wise, how am I directing my scalpel to the cricothyroid membrane?
You know, it sounds harder than it actually is. You know, your finger was in a place, you put the scalpel in the place it was. Sometimes you do hit cartilage for a second. In reality, it's easier than in description. And much like Andy said, I train people after that vertical incision to close their eyes on the training model, not in real life, on the training model, such that they learn that exact technique you're mentioning, Nick. And since you can now 3D print models of human airway and practice this on your own, you practice that exact move. Okay, I have my finger on the spot. I move my finger. Is my scalpel in the exact spot my finger was? And you realize, yeah, after you try it 3 or 4 times on a model, it absolutely is.
Andy, what are your thoughts on finger in hole with blade?
Well, just to come back on the finger in hole problem, we were discussing about whether or not you lose the hole. I mean, when you teach this on cadavers, everyone wants to be the first one on the cadaver because they all know that by the time the first guy has finished his go, that everyone can find the hole. They can all find the hole he made. So, you know, that is a very good demonstration that you can find the hole. Believe me, you don't even need to look at the neck to find the hole. You just run your finger up and down. You find something hard, which is, you know, not trachea. You come to the cartilage, and you can feel the hole. You don't. It's not a sophisticated thing. You know you're in. I think that on the side issue, the technique that we described in the critical care guideline, which came out in 2018, was very similar to the technique that they described in the 2015 guideline. And we did that for a political reason, because we didn't want to release two guidelines which said different things. But I'd already moved on from the 15. I never liked the 15 guideline technique anyway, but for political reasons, I accepted that. But I did change one thing, and that we dropped the side you stand on, because the 2015 guideline was you stand on the left shoulder. I've never seen an ENT surgeon ever stand at the left shoulder. I've done a few hundred perk trachees. I've never stood at the left shoulder. I mean, maybe Scott does some pre-hospital stuff, and he just can't stand at the right shoulder because there's a car up against it or something like that. But I think every right-handed person in the world wants to stand at the patient's right shoulder naturally. So but I would concede that it ultimately doesn't really matter, but stand wherever you're the most comfortable, and most people are comfortable on the side of their dominant hand. But if you want to stand the other side, it's a free world. It's a free country. And I think that the DAS 2015 guidelines are coming in for a bit of stick here from different angles. And in their defense, because I am a DAS man, I've got to defend them. They don't pay me if I don't.
You're a Puma man now, Andy.
Basically, in 2015, the DAS writing group made a massive call, and they came down heavily on the side of scalpel-based techniques, and that was right. That was correct. I think then there's a secondary issue of the actual technique that they described. I'm not a great advocate for that technique. I think scalpel finger bougie tube is superior. I hope the next iteration of the guideline will be scalpel finger bougie tube. But remember, back in 2015, the big question was, should we just go scalpel? Right? And the actual technique was secondary. It's important, but it's secondary. And they got the big call right. And just to remind you, I wasn't on that group. So, but they got the big call.
Both supporting it and washing your hands of it in one move. I'm just going to come. We're very short on time. I'll come back to you in a moment, Reza. Just T, I think, has a few things to say, and just on this side thing, I don't think we need to spend a lot of time on it. It's purely an ergonomic issue related to the how you do the movements involved in each technique, isn't it?
Thanks, Nick. Look, I think it's really great that we're having this discussion. So thank you, for setting this up. And how are you going, Andy? It's kind of good not to have you sitting next to me, because I know we'll never agree on the sort of one only technique. But there's lots of stuff that Scott, Reza...
I love sitting next to you at dinner, T.
Yeah, well, next time, next year, Sunshine Coast. Okay.
Anyway, move along.
So I don't have time to sort of say what I agree and disagree with for all three of you, and there's a lot that I have agreed with. I think I'd just like to say two things. Firstly, I mean, I've never done a real kyco, so I'm not speaking from that sort of experience, but I guess I spent 10 years in the UK with a whole DAS approach. And then I've spent the second 10 years in WA with the ANZCA approach, as well as the privilege of the wet lab, which we run every week, by the way. So the technique and approach that has been recommended by the Royal Perth team has been developed after watching over 10,000 cryo situations with people in a live sheep model with real-time bleeding, because they've been talking about bleeding with cadaver and the George Kovacs. But I disagree with, there's not a lot of evidence here. So I think two things to end on. One, I think EBM, not just evidence-based medicine, but I think we need to think about experience-based medicine. So that's kind of taken into account, you know, everything that we see people failing at and the nuances and the devil in the detail. I think the second thing, and Andy, to quote you, you said, it's a free world. So then you're contradicting yourself by saying we only have one technique and people can only do one thing. I agree it needs to be simple, but I think, you know, having two techniques might increase your chances of success. For example, a Cat 1 section, right? You're not going to go and, you know, you're a one-trick pony and you can only do a GA, right? You might have a spinal or a GA. You do want to keep it simple, but at each sort of decision tree, palpable, impalpable, you know, endpoint, are you successful or not? So you're going to move on. And I think, you know,
but do you want to get to the end of an algorithm only to enter another algorithm?
I think you're
Palpable
simplifying it
in a
too
lot of
much. And the
people's hands
military,
is
Andy,
actually not palpable. They get it in the wrong place.
but in the military, when you said 80-95% success rate, looking at Royal Perth Hospital, our cohort of patients, public, lots of trainees, lots of overseas, different techs from different, you know, experiences, you're never going to get that to be replicable.
Okay, we need to round up. This is a fantastic discussion, but unfortunately we're out of time. I just want to ask the audience, just a show of hands, ignoring what you've learned today, up till now, if you're asked to do it, who would have gone with the stab and twist Andy Hurd technique? Hands in the air. Okay, and keep your hands up, and leave them up if you're not an anaesthetist. Okay, so maybe, oh no, so predominantly anaesthetics are doing stab and twist. Hands up who's doing the scalpel finger bougie or would do the scalpel finger bougie. Leave your hands in the air if you are an anaesthetist. So significant number of anaesthetists there have moved to scalpel finger bougie as well. So that's interesting. Anyone change their mind based on the discussion today? Wow. And which way did you go? Go on to finger. So you've won some people over for finger, folks. Okay, we will wrap up, I think. Sorry we didn't get much chance for questions, but thank you to our panel, Scott Weingart, Reza Nouraei, Andy Higgs, Adam Rehak, Tito, David Vokes.
Couple of announcements. The food, because of the space available, the food is going to be split between this floor and the floor below. So please distribute yourselves evenly because there'll be more seating downstairs and just more opportunity to be more comfortable. I would just like to add also that it's been quite an amazing achievement by Australian anaesthetic departments to have a very standardised approach to neck rescue. And I think the underlying safety factor is that the training and the equipment underpins the technique you'll use. So don't change technique if it is not aligned with the equipment and the training in your department. So that, I think, has got to be, this is a very high-level theoretical discussion, but if you're trained in a technique, you've got the equipment for that technique, don't change unless that is aligned with what's available to you. Stick with what you're good at.
There's just scan the QR code to get a whole lot of references relevant to the debate and a couple of the videos. Whilst, as Adam says, don't change your technique, but it's certainly worth starting to have the discussion.